on from this from a previous session. So this mastery live classes started on the 1st of June, and these are all the salient features of it. It's going to helpful for the university exams as well as our NEET PG and FMG. Today's topic will continue from yesterday's. Yesterday we finished with the stomach and the small intestine. Today we're going to start with the appendix, okay? And then following appendix, we'll come to the large intestine per se, right? And a little bit knowledge about the some of the blood circulation in our gut as well. These are the major topics that we're going to cover today in the form of long and the short questions. These are some basic features of Auricle, live recorded classes, notes and MCQs, and some subscription plans are over here, right from 15,000 for 3 months to around 50,000 for mentorship program for a whole complete year. In between, we have a 6-month plan for 30,000, and these are all the same features of those plans. Don't forget, and there's an offer which is going on, and it's valid only up till the 15th of July. Okay, and here in 13,499, that is 13,500 approximately, we have got you're getting a combo plan. It's a limited period offer. Listen carefully. It's a combo plan for 13,499. Valid up till July 15th, where you get all the features of the app plus as well as the hard copy, the books, the hard copy meaning the paper book, all that, right? These two things is what you're going to get in this combo plan, and it's a limited time period offer. So remember this. Fair enough. Let's come to our discussion, and let's move to the topic straight away. Okay, just a second. All right. Okay, so here we have this. There's a topic that we discussed yesterday regarding the small intestine. So this was the last topic, the Meckel's diverticulum that we discussed. So today we are going to start with the cecum, and then we'll slowly proceed. Right? Okay, so let's start the topic and make your own notes. Have a pencil and paper, and try to make your own notes. Any queries, write in the comment box. So explain about cecum can be a question. Okay, cecum. Cecum, we all know, is the beginning of the large intestine, and it is basically a large blind sac. Okay, when we use the word blind sac, it means that one end is closed and one end is open. Okay, the closed end is known as the blind end. So this blind end means there is a closed end over here. Okay. So you will have a closed end like structure. That is our cecum. The other peculiar feature of cecum is that cecum is one of the rare structures in the body whose length is less than their breadth. So it is around 6 centimeter in length. Breadth-wise, it is a bit more than the length, that is 7.5 centimeter. Where is it located? Around the right iliac fossa. Now, this word over here, which I said already, that it has a blind sac. It has a blind sac that is a closed end. Now, this gives rise to a very important clinical situation, right? There can be inflammation inside the cecum. There can be sort of inflammation, meaning by suppose some bacteria, some pus starts to collect over here, and there's no place for it to go. So this therefore becomes prone for infections and perforations and inflammation like that. And as you will see later on that you have this appendix also situated over here, and there's a reason why appendix also involved in various infections leading to appendicitis. Okay. This is one important point I want to tell over here about the being a blind sac. What are the disadvantages? Relations of cecum: anterior, you have this intestine and the abdominal wall, obviously. Posterior, you have these posterior abdominal wall muscles. Okay, just a second. Right. So some noise was coming, so I hope it's not again. Yeah, so relations we are discussing. Anterior, we have the coils of intestine, and posteriorly, we have this all the structures. These are basically structures lying in the posterior abdominal wall. Posterior abdominal wall over here. You can see the muscles. Basically, we have the psoas and the iliacus. This is right psoas and iliacus. These are the muscles of posterior abdominal wall. We have nerves also coming from the lumbar plexus and some vessels over here. And also appendix can be behind the Cecum, if the appendix is retrocecal in position. Retro means behind. So you will see the appendix has a lot of different positions. The most common the position is retrocecal. Okay, and more than 50% cases, the appendix lies behind the cecum, known as retrocecal position. Retro means behind. That could be post relation. There can be question asking you about the ileocecal wall. So as we all know that you have this ileum coming out, right? And then it opens into the cecum. And cecum, as you have already have seen, it has this blind sac over here with the appendix lying somewhat down. So this structure over here, this is what is known as the ileocecal wall. This is what is known as the ileocecal wall over here, right? And it's a wall. Therefore, it's quite important that if you have any substance that is coming inside the gut, that this ileocecal wall is one of the most constricted places in the whole gut. So suppose, for example, clinically, if I may tell you, there might be at times that the stones from the gallbladder, right? The gallstones might perforate the gallbladder. And as we discussed yesterday, that gallbladder is related to the duodenum. So these stones, if they perforate the gallbladder and the duodenum, they might come inside the gut. And then these stones will go through the duodenum, jejunum, ileum. Because between duodenum, jejunum, and between jejunum and ileum, there's no wall. So finally, what will happen is that these stones over here, if they are large enough, they might obstruct over here, giving rise to small intestinal obstruction signs and symptoms. I'm just giving an example of gallstones. That can be possible. Okay, I repeat again what I'm saying is sometimes it might happen that the gallstones which are inside the gallbladder, they might perforate the gallbladder, and as we have seen that gallbladder is related anterior to the duodenum, right? Mainly to the first part duodenum and bit of second part also. So those gallstones might perforate the gallbladder as well as the duodenum, because duodenum and gallbladder are stuck to each other like this. So gallstones might come into the gut. Those are stones. So stones might come and obstruct at the ileocecal wall. Remember that. Okay, so clinical application I'm telling. So the lower end of ileum opens into the posterior aspect of the cecum junction. Ileocecal opening is guarded by this wall overhead, right? This I'm telling you the clinical importance. That is how you will generate some interest in it. You can have cecum has some clinical anatomy, like they can be amoebiasis causing amoebic dysentery. There can be infections and inflammations and some carcinoma also. Inflammation, as I told you before itself at the beginning of the topic of cecum, that it is a blind sac, right? Just a second, yeah. It is a blind sac. So blind sac has its own disadvantages, as you can see from this clinical anatomy. Okay, let's move ahead now. Coming to the topic of appendix. Now, appendix, as we already know, is connected or is attached to the cecum. Okay, so let us see. The vermiform appendix is a worm-like diverticulum. It is a worm-like diverticulum that arising from the posterior medial wall of the cecum, about 2 centimeters below the ileocecal orifice. Okay, so just imagine you are in the OT table and you are seeing the small intestine. You take the ileum out and you trace the ileum. You come to the distal end of the ileum. That is the ileocecal junction. Just a couple of centimeters below that, then you look for the base of the appendix. That is how we can reach the appendix, because straight away if you go and search for appendix is very small. And looking at it inside the entire abdominal cavity is not easy. So you should know some basic landmarks. So ileocecal junction, and just below it, couple of centimeters below it, you have the opening of the appendix. The appendix is not that you just, the appendix is not like you are seeing it. Appendix can be anywhere, meaning by the base is fixed, but its tip can move anywhere. We'll see the different positions. Dimensions again are too much of variables. It ranges from 2 to 20 centimeters. So average comes out to be around 9 to 10 centimeters. Diameter is only around 4 to 6 mm, average around 5 mm. Position, obviously, it is at near the ileocecal junction in the cecum, so it is in the right iliac fossa. Okay. The base is fixed, as I said already, that the base is fixed, but the tip can point in any direction. That is the point. What is the use of it? Why are you stressing so much on this point that the tip can be, okay, let it be, but the base is fixed, yes. The tip is pointing in any direction. Their clinical importance is that if a patient comes to you with a pain in the right iliac fossa and you're suspecting appendicitis, looking for the signs and symptoms of appendicitis, it depends a lot on the position of appendix. Is the position in front, is the position in back, is the position more middle, more lateral, like that. Well, it's an inflamed organ. Inflamed organ, imagine a red hot organ. So wherever that red hot inflamed organ is going, it will give symptoms or signs in that way on. That is the importance of having different directions, a knowledge of it. You should know. So some directions are given over here, like the pre-ileal, post-ileal, sub-ileal. I hope you can understand from the words what they mean. Before ilium, behind ilium, below ilium, right? Pelvic position that is going into the pelvic brain. And these all these clock positions are, all of us are aware of the clock, right? It's very straightforward. There's a clock over here. You have 12, 3, 6, and 9 over here. So 1 or 2 o'clock position, these are sub pre or post ileal. Sub-ileal is, say, this position. Pelvic position facing towards the pelvis. All these are the facing of the tip of the appendix. Then they are saying subcecal, okay, below the cecum, 6 o'clock position. Paracecal, retrocecal. Retrocecal is going over here, but behind the cecum. So tip can point in any direction. So just understand in this image, suppose this red circle is the base. That is fixed. But the tip can point out in any direction. Tip can point out in any direction. That's the whole point. Most common, already I told you that retrocecal and pelvic position, they are regarded as the most common positions. The most common positions. Fair enough. Here is an image. You should practice this image. It's very simple. You just have to draw what? You have to draw an ilium over here, draw cecum, and then show the base appendix and different directions. Tell them which o'clock position is this. Okay. Now, some aspects of the appendicular opening. So, as we already have seen, that is 2 centimeter below, right? There is a special wall known as wall of Gerlach, okay, that guards this appendicular opening. Lumen appendix might be obliterated after mid-adult life. Okay, so see the appendix. Why the appendix is so much stressed upon is the reason we all know that we all have heard of the disease that is, which I'm already mentioning a couple of times, is the appendicitis. That is inflammation of appendix. That is inflammation of appendix. Normally, it occurs in case of teenagers, young people, teenagers, normal age group, it occurs, small children, teenagers, like that. Okay, because again, appendix is a blind tube. It's a very small, lumen is very small, around 2 to, let's say, 8-9 centimeter long, and it can easily get obstructed. That would lead to appendicitis. Okay? Therefore, it is very commonly very important for doctor, for people like us, to diagnose it, look for the exact symptoms, and then treat accordingly. Whether surgery is required or not, or what surgery is required at what time, that is what we should know. Because if we are suspecting appendicitis, the patient should be rushed to the hospital, obviously. Why? Because if you are not controlling the inflammation, that might rupture, and later on it gives rise to the total inflammation of the peritoneum, that is known as peritonitis. So even if you are suspecting appendicitis, the patient should not be sitting at the home having painkillers only. Patient should be rushed to the nearby hospital. Okay, better management can be taken care there. About the peritoneum, you have an appendix of it that is known as mesoappendix or appendicular mesentery. Blood supply, we all know that the region of appendix, because midgut is from where to where? It is from second part of duodenum to the proximal 2/3 of transverse colon. This is the basics. And all of this is supplied by which artery? By the superior mesenteric artery. Therefore, ileocholic branch. It's a branch of superior mesenteric artery, and its appendicular branch will supply the appendix. Venous drainage will go to superior mesenteric. Okay. Now here we can see this is the ileum, that is the appendix, that is the base appendix, and this is the appendicular artery. And this whole, if I may use a highlighter, this is whole is your mesoappendix. This is mesoappendix over here. You can see the ileocecal artery is giving off the appendicular artery. One more additional point, if I may say, that this artery is basically a sort of end artery, and there are very few collaterals over here. There are very few collaterals over here. Therefore, if it develops any thrombus and obstruction over here, then this part will start the necrosis, and that could lead to perforation of the appendix, and that could lead to peritonitis. Therefore, appendicitis cases are to be taken seriously. Getting a point? Due to very few collaterals, I'm repeating again, if any thrombus occurs in the artery due to any infection, then that part of the appendix that is being supplied by that particular artery will obviously undergo necrosis. That is known as infarction, ischemic necrosis, and therefore this part may die and the contents inside it may come out, leading to or giving rise to peritonitis. So initially it was only limited to appendix. Now that inflammation has reached the entire peritoneum. That is a serious situation now. Already appendicitis is serious, but then more serious. Come to the nerve supply, you have sympathetic and parasympathetic from T9, T10, and the vagus part. Again, lymph nodes, you have the ileocecal nodes over here. Coming to the clinical anatomy, now this is interesting. Obviously, appendicitis. Okay, I've already discussed the removal of it, appendectomy, fine. Now come to these couple of points, which are McBurney's point. And clinically, you should know that at which stage, is the pain in appendicitis. Now that is crucial. McBurney's point is actually telling us the point of maximum tenderness that is found in the appendix. So here you have to take two bony landmarks or two landmarks over here. One is your anterior superior iliac spine and one is the region of umbilicus. Okay. Now you join these two with a line, the right side ASIS and the umbilicus. And then at the junction of lateral 1/3 and medial 2/3, this is the point of McBurney's. This is roughly the point of the base of appendix. I repeat again, ASIS is anterior superior iliac spine. It's a bony landmark. Umbilicus, we all know umbilicus. You try to join them, and somewhere in the junction of lateral 1/3 and medial 2/3, somewhat around here, you have this McBurney's point, which is roughly around the position of the base of appendix. There, most of the pain is felt. Now, pain caused appendicitis, these three things is a must know. First, the pain is felt where around umbilicus, initially. So the patient comes to you, say teenage group or say particular those age group, with a severe pain, colicky pain around the umbilicus, one of the differential diagnosis, one of the diseases in your mind, it should be appendicitis. Initially, the pain is periumbilical pain. This is a referred pain. Appendix is not in the umbilicus, but it's a referred pain. Same dermatomes. The mind gets confused. So brain gives a signal, okay, pain is occurring on umbilicus. That is the initial part. Now, later on, then this pain will go where? Later on, this pain will go around the McBurney's. But initially, it is where it is periumbilical. That is the point. Now, if the appendix is retrocecal, that is behind the cecum, then you should know that when we are reading cecum, then the posterior relation of cecum was posterior abdominal muscles. So when the appendix is behind the cecum, then appendix is basically, in that case, the inflamed appendix is basically in front of the posterior abdominal wall muscles. So at that case, extension of the hip joint may cause pain because appendix is disturbed by stretching psoas major muscle. Basically, there the appendix is sitting directly on psoas major muscle. That is known as the psoas sign. The moment you ask the patient to flex or extend the hip joint, the pain will elicit. Pelvic appendicitis pain, now felt when thigh is flexed and rotated because of operator internal stretch. So depending on where the appendix is actually lying, it might irritate the operator internus, it might irritate the psoas major. Therefore, if the psoas major is irritated, the problem will be there in the joint flexion extension. If the operator internus is irritated, the problem will be there in the medial or lateral rotation. So if you do those movements in the lower limb, the hip joint particularly, and if the pain aggravates, then it can give you a rough idea of where exactly the pain is. Okay, though obviously you have to go for ultrasonography and other radiological investigations nowadays to exactly see where the organ is, what is happening. Okay, then there can be things like appendicular dyspepsia. Okay, when in the appendix, like Meckel's diverticulum, you have some mucosa of the gastric part, like that. Okay, here's showing us the inflamed appendix. Now, this was about our cecum and appendix. Cecum, remember, the location, appendix, remember, different positions, and its applied aspect. Now come to the large intestine, that is the colon, or basically we are dealing with what the large intestine over here. Yesterday we have seen that what are the basic differences between the small and large intestine. We are not going to repeat it again. We should know that the major role of large intestine or the colon is basically absorption of water, secretion of more mucus so that the stool is formed, and some absorption of nutrients as well might happen simultaneously. The large intestine is present basically at the periphery of the abdominal cavity. If you look at the patient's abdominal cavity, on the sides, periphery, you have the large intestine, as you can see over here, and in the middle, you have the small intestine. So SI is in the middle and LI is at the periphery. That is it. Here we are dealing mainly with colon. Colon has four parts. You have ascending, transverse, descending, and sigmoid colon. Needless to say, this is ascending colon, that is a transverse colon, that is a descending colon, this is the sigmoid, S-shaped sigmoid colon. Out of these, all four, we know that transverse is intraperitoneal and sigmoid is intraperitoneal, while both of these ascending, descending are mainly retro. I'm using the word mainly retro. They are actually secondary retro. Initially, they were not retro, but during embryonic life, they somehow lose their mesentery and then they became retroperitoneal. That's all. Just imagine the ascending, descending are sort of fixed, and transverse and sigmoid are sort of slightly movable. That's the whole thing. Length over here, there's a whole table given over here with the all the four parts of colon, and the differences are mentioned. What is the different length? So remember length. There can be questions like the shortest part, this is the shortest part. The longest part is this transverse colon. Extend from way to way, that I guess we can understand. And also to remember that this part is known as the right colic flexure. This part that is known as the left colic flexure because this is a flexure. And the organ over here is the liver, so that is also known as a hepatic flexure. And here you get the spleen, so that is known as a splenic flexure. And do remember that they both are not at the similar level, but the actual picture, actual images, because liver is obviously quite bigger in comparison to the spleen. Therefore, liver will tend to push the hepatic flexure downwards. So basically, the hepatic flexure to splenic flexure, the thing goes like this. The thing goes like this. That hepatic flexure will be at a lower level and splenic flexure will be at a higher level. Basically, you can understand that due to the difference, inappropriate differences between the size of liver and spleen, the liver will push the hepatic flexure of colon more inferior. You can even understand the vertebral levels are also different. The vertebral levels are different. Splenic flexure will be around say T12 or L1. Because see, spleen is just below the diaphragm, and then you have this around T12, you will have this. Hepatic flexure might go up till L2. Till L2. That we'll see more. Okay, now you understood this. Relations, anterior relations, you can just have a look at it. Okay, what will the relations of ascending colon, descending colon, transverse sigmoid colon? Anterior relations of ascending and descending colon basically are having the coils of small intestine. Why? Because both are retroperitoneal. Here you have the greater omentum, here you have the sinus loop over here in the pelvic wall, in the sigmoid colon. Posteriorly again, ascending and descending colon, look, both of them are retroperitoneal. So behind them is basically the post-abdominal wall. If we look over here in case of the transverse, this is the transverse colon over here, it's posterior relations. Now remember yesterday we talked of duodenum and attachment of transverse mesocolon and all that, right? So behind the transverse colon, you have the second part of duodenum. You have the same level, you have the pancreas. Then you will have the small intestine behind the colon. But in other cases, you are seeing anterior relations are having also small intestine. Okay, in ascending, descending colon. But here transverse colon lies in front of small intestine, and obviously behind lies transverse mesocolon. Basic differences. Now these are flexures that I already told you. So right colic flexure lies at the junction of ascending colon and transverse. Left colic between these two junctions. Basic difference of these two junctions, as you can see from this image on this table as well. And it's a good idea, guys, that you guys also try to make the tables like these only in your theory exams, particularly when you're giving the theory exams. Guys, try to make the table like this. Okay, that will help in your scoring as well as in for the examiner also. It helps in basic understanding. Okay. So hepatic flexure plays entry on the right side as on left side. See, it is a sort of right angle. Hepatic flexure is sort of right angle. Splenic flexure is sort of acute angle like this. Is lies on the right side, right kidney lies on the left side, so mainly around the spleen. Spleen is then in front of left kidney. Supplied by right colic artery, because understand this part is actually a part of midgut, while this splenic flexure, this part is actually a part of hindgut. Why? Because it was a proximal two-third of colon where you have the midgut, and after that you have the hind. So therefore, the blood supply will also change. Right colic artery will be a branch of which artery? It will be a branch of superior mesenteric artery. Left colic artery will be a branch of inferior mesenteric artery. There's no ligament on the right side, but on the left side, there's a ligament known as a phrenico-colic ligament. Now, if you guys have made notes or listened to my previous lectures, in peritoneum we have discussed the importance of phrenicocholic ligament. And this is the reason why the collection of fluid in the supracholic spaces does not directly reach the left paracholic gutter because of presence of this ligament. Second thing is, it is the presence of this ligament which actually holds the spleen at its place. It will also help in holding the spleen at its place. Okay. And therefore, the spleen, when it enlarges, it cannot go directly downward. The spleen, when enlarges, goes obliquely to the right side and obviously downward. I repeat again, in cases of splenomegaly, let me tell you over here, because that was a recently asked question. Okay, let's use this space over here. Just be with me, guys, for 1 second. See, this is the, say, the umbilicus, right? This is, say, the spleen over here. Okay, this say the spleen. When the spleen will enlarge, suppose this is the spleen. When the spleen will enlarge, the direction of its enlargement will be towards the umbilicus, obliquely downwards and towards right, and then it might even go to the right iliac fossa. This is the direction. Questions have come initially that why doesn't the spleen enlarge inferiorly? The reason is that you already must be guessing by now this presence of this ligament over here known as phrenicocholic ligament. It's between the diaphragm and the colon over here. Due to which the splenomegaly or the enlarged spleen does not go directly down. Okay, that's an important question. Remember importance of which ligament? Phrenicocholic ligament. Okay, the right cholic flexure at around L2, this is present around your T12 level. So this we already discussed that it's not a horizontal structure, it's a oblique structure. Okay, here's an image, all these parts of colon over here. And some question we'll discuss separately in our other classes. Sunday also we're planning a class on our MCQs as well. Okay, fair enough. Now let's see another topic on the celiac trunk. Now come to the arteries. Celiac trunk is supplying which part of the gut? It is supplying the foregut. We all know it supplies the foregut, coming from the abdominal aorta. Yesterday, while discussing stomach, I already told you about the celiac trunk quite in detail. So today it might be very simple. And if you remember, then we discussed it has 3 branches. You can remember the mnemonic, if not, no problem. It was LHS, left hand side, left gastric, hepatic, and splenic artery. And it supplies the foregut. So it is an artery of foregut. Now let's see what is being done over artery of foregut. So it has a short trunk. So itself, celiac trunk will have a short trunk, hardly this much, hardly 1 centimeter. And then suddenly gives off branches and supplies alimentary canal up till the opening of bile duct, up till your junction of foregut and midgut. Origin, it arrives in the front of aorta just below at the level of L1. So it is around, say, L1 upper border. You have the origin of the celiac trunk. Here is a lateral view of the aorta. This is your abdominal aorta over here. Try to understand this diagram. This is an abdominal aorta over here with the anterior side over here, posterior side over here. Okay. So celiac trunk is basically L2 upper, or you can say T12 L1 junction will be a better term over here. So anterior posterior, this is the abdominal aorta. What is this? This is our abdominal aorta. And here you are seeing this over here is the celiac trunk. Let me highlight over here, celiac trunk. Below celiac trunk, another artery coming in forward is superior mesenteric artery, and below this you have inferior mesenteric artery. These are 3 arteries which are supplying the gut. And celiac trunk supplies the at foregut. Okay, celiac trunk will supply the foregut over here. Superior mesenteric at the L1 will supply the midgut, and inferior mesenteric at L3 will supply the hindgut. This is what we should do. Then if you look over here, we also discussed when we are discussing duodenum. If you remember, we discussed a syndrome known as SMA syndrome, superior mesenteric artery syndrome, also known as, and the name of that syndrome is the nutcracker syndrome. Nutcracker syndrome. I told you that sometimes this angle between the superior mesenteric artery and aorta, it might decrease, and when it decreases, then it might compress these structures. Which are those structures? Left renal vein, uncinate process of pancreas, and third part of duodenum. This was, or actually third part of duodenum is what we were discussing yesterday, and then this syndrome came into my mind, which we discussed. Remember this also. So celiac trunk, discussing right now. But a couple of things also below celiac trunk are superior mesenteric and inferior mesenteric artery. Branches of celiac trunk, I am sure left hand side, splenic artery is the largest branch. Okay, left gastric, hepatic artery, and splenic artery. We already discussed. Left gastric artery is the smallest branch of celiac trunk, supplies the largest area of stomach. It supply big area of stomach. And yesterday also we discussed that left gastric artery will lie where? It lies in the lesser omentum. Remember? Branches, esophageal and gastric branches. Fair enough. Common hepatic artery again will go towards the liver, but before it goes to liver, it gives off right gastric artery and gastroduodenal artery, GD artery. GD artery, if you remember, it passes behind which part of duodenum? It passes behind first part of duodenum. And therefore, we are discussing yesterday that in case of posterior perforation of the duodenal ulcer, this artery might get damaged. Okay, so common hepatic artery passes right over the upper border of pancreas, fair enough, and the gastroduodenal artery, right gastric artery mainly branches. As the name is your hepatic artery and gastroduodenal, it will also give branches like duodenal branch. And finally what happens is that there's a proper hepatic artery which will give off to the right and left lobe of liver, the right and left hepatic artery road. Okay. Next is the splenic artery, which is the largest branch of celiac trunk. Okay. This is the largest branch. It is quite tortuous. It is quite wavy in appearance, and it runs at the upper border of pancreas. Okay. If we look at the course of the splenic artery, it is running at the upper border of pancreas. Let me write over here, though it might come later on also, but let us write the course at the upper border of pancreas. So we want to find out the splenic artery. If you have reached the pancreas, then you will easily find out the splenic artery. It lies at the upper border of pancreas. Okay, it runs towards the left behind the stomach, where is the height of the spleen. And we have also learned yesterday that splenic artery will give branches to the stomach, like the short gastric and the left gastroepiploic artery, if you remember. So pancreas, what are the different other branches it gives? Pancreatic branches because it is running over the pancreas. Then short gastric branches, left gastroepiploic artery, okay, and so obviously branches to spleen. That is needless to say. The name is splenic artery itself. Okay. Now coming to the superior mesenteric artery, which area will it supply? It will supply midgut. So we should know what are the parts in midgut. Superior mesenteric artery is the artery of midgut. It supplies all the derivatives of midgut. So if see, it is a very simple artery to learn superior mesenteric artery branches. Why? Because superior mesenteric artery and inferior mesenteric artery, they are supplying mid and hindgut. So if we know what is there in midgut, the branch's name will be like that only. Let me tell over here. Midgut parts are, you have the say terminal part of D3, the duodenum, right? Then you have the jejunum, right? Then we have ileum. Then we have a cecum and we have appendix also. Then we have ascending colon, okay? And we have proximal two-third of T colon. Now, if I name some branches over here, for this lower or the terminal part of the duodenum, we have inferior pancreatic or duodenal artery. For jejunum, we have jejunal branches. For ileum, we have ileal branches. At this location, we have ileocolic artery. Okay. For ascending colon, we have a right colic branch. For transverse colon, we have the middle colic branch. See, simple as that. Now you know all the branches. This is what is to be shown later on. So these are all the parts of what? All the parts of the midgut, and these are all the branches of the superior mesenteric artery over here. Simple as. Okay. Let's look at this 4-5 lines over here. So our pointers over here, these are worth noting. Listen carefully and try to understand them. Supramesenteric artery, remember the syndrome also, arises from the front of the abdominal aorta at the level of L1. Fair enough. 1 centimeter below the celiac trunk. So it is just below celiac trunk. It runs downwards and to the right, forming a curve with its convexity towards the left side. Fair. You can omit that. At the origin, it lies first behind the body of pancreas and then in front of. It is very much related to the pancreas. Now let me show you over here only. If I try to make the pancreas, suppose this color we use for the structure pancreas. Now, this is the region that is head of pancreas. This is uncinate process. UP is uncinate process. This region is the neck of pancreas. This region is the body of pancreas, and this is the tail of pancreas. What happens actually is that the superior mesenteric artery, okay, is actually behind the origin is behind the body of pancreas. It is behind the body of pancreas. Then what will happen is it will come in front of the uncinate process. That is what they are trying to say over here. Understand this. It crosses the third part duodenum. Now, why third part? Because again, common sense. This is the first part over here, the second part over here, and the third part over here. The third part will go like this. Therefore, the superior mesenteric artery, as it is crossing uncinate process, it will also cross the third part of duodenum. And therefore, you have SMS syndrome. The pancreas and third part duodenum might be compressed. It crosses third part duodenum and enters the root of mesentery. Here you have the attachment of mesentery. So it will now enter the mesentery to supply the medical. It terminates at the right iliac fossa by anastomosing with the branch of iliac artery. Now, relations. Above the root of mesentery, what is the relations? And here you have the pancreas splenic vein. Behind you, we obviously have all the retroperitoneal structures. Within the root of mesentery, we have it crosses the inferior vena cava and the right psoas, and throughout it goes accompanied by this. This is actually important. Forget about the where, because once you draw the diagrams, relations, some relations you can easily write it down. See, another trick I want to share with you over here. If you are finding any topic difficult in anatomy, there will be few topics. No matter how much you study, there will be few topics which you are not very much comfortable with. Let us be honest over here. So what you do at those topics, at least practice 2, 3 diagrams of that particular topic from wherever it is. The moment you make diagrams in anatomy, try to explain that diagram in a written format as simple as that. So in the meanwhile, you can write something. You can write half of 1 page or 2 page like that. So if you know the diagram, then you can elaborate that diagram. Okay, this is post related to this, then it passes like this, then it is related to this structure, whatever you are making in the diagram. That organ is obviously related to all those structures. That is why it is there in the diagram, most probably. That way. Here, remember, throughout the course, it is accompanied by superior mesenteric vein, which lies on its right side. Now, this is a important part, that it is lying on the right. The vein is lying on the right side. What I mean to say is, this is superior mesenteric artery, and this will be on the right side of it will be the superior mesenteric vein. That is the point. Okay, there for different branches, I guess we already have seen that inferior pancreatoduodenal, middle colic, right colic, ileocolic. Yeah, few times question have come that branches come from the right side of the superior mesenteric artery. Remember, on the left side, you only have jejunal in iliac branches. If you look at the diagram of superior mesenteric artery now over here in the beginning, these are all this is actually our SN. Because this is the right side, that is the left side. All these branches are either jejunal branches or iliac branches. Why? Because this is jejunum and ileum. What we are witnessing over here, this hole is what? This hole is mesentery. So the branches coming from the left side are mainly jejunal iliac branches. All other branches to the ileocolic, right colic, middle colic, IPDA, all are coming from the right side. If you look at the diagram, things are obviously self-clear. Things are always self-clear. Okay. Here they are showing us the relations of the superior mesenteric artery. So this is the superior mesenteric artery over here. Let me change the color. Yes. Okay, and this is your uncinate process. That is your third part of duodenum. You can see it is running in front of it. Okay, fair enough. So now inferior mesenteric artery. So it will supply which part of the gut? It supplies hind gut. Hind gut, we should know what is there in the hind gut. Mainly, you have the distal part of the transverse colon. Fair enough. You have descending colon, right? You have sigmoid colon, and you also have a rectum. So basically, the arteries, let me tell you beforehand only, all these are written already. The artery supplying it will be, for these two areas, we have the left colic artery. For sigmoid colon, we have the sigmoid branches directly. And for rectum and all these the parts, we have the superior rectal artery. Which artery? Basically, in IMA, only 3 branches are there. That is the only good news I can tell you. The past 30-40 minutes, the only good news I can tell. There are only 3 branches of inferior mesenteric artery. If I ask you its vertebral level, that is L3. So why is this important? Again, I am telling you again and again. Nowadays, much of the medical science is dependent on imaging. Right? I'm sure you guys must be knowing. Okay, so CTs and all are very, very common nowadays. So you should know this. Okay, here is the inferior mesenteric artery. They are showing this is the your beginning of IM at around L3. So at L4, see what happens at L4, the aorta will bifurcate into two common iliac arteries. Aorta bifurcates at around L4 level. So at around just one vertebrae above, you have the origin of the inferior mesenteric artery. So arises from the front of aorta, behind the third part of duodenum. Yes, duodenum also, remember yesterday we discussed that duodenum we have 1, 2, 3, and 4 parts. What we discussed, what were the vertebral levels? L1, L2, L3. Right? So right at L3 over here, behind you have the aorta, this is the IMA that is coming out, L3, L3. Course and termination, it runs behind the peritoneum and middle to the left ureter and foramen. Then branches, it gives off the left colic and sigmoid and also the superior rectal artery. Okay, you see it over here as a terminal branch. Why? Because already told you mainly 3 branches are there. Now coming for the vein side. Superior mesenteric vein, I've already told you in the beginning, not in the beginning, but yeah, when we are discussing the superior mesenteric artery, that this vein will drain the midgut. But where will the blood go from here? Will it go to the IVC? No, the blood will go where? To the portal vein, basically into the liver. And this vein lies to the right of superior mesenteric artery. Right? Superior mesenteric vein is a large vein which drains blood from the small intestine, all these areas. It begins from the right iliac fossa. It accompanies the superior mesenteric artery. This read a couple of times, you will get to know about it. The vein lies to the right side. This actually is important. Why? Let me tell you here only, else you will might confuse this why they are again telling it is on the right side. Do we get confused while doing dissection that it is an artery or a vein? No, we don't. We normally are not confused. We can easily distinguish artery from a vein. Then why it is being repeated again and again that the superior mesenteric vein over here, this vein over here is to the right side. Reason over here is that during embryology, there is a topic which you guys must have gone through is the rotation of midgut. There's a topic that is in embryology you study the rotation of midgut. In cases of malrotation, when the rotation has not occurred normally, it is a very important sign that the superior mesenteric vein is on the left side. That is the whole thing. So in malrotation, there can be superior mesenteric vein like this, and to the right of it, you have a superior mesenteric artery. If this is being seen in any particular case, it is probably a case of malrotation of the gut. That is also important MCQ. Okay, coming to the topic over here. So here we are seeing the superior mesenteric vein. This is whole is superior mesenteric vein. This is splenic vein over here. Okay, and actually these two veins they join to form the portal vein. And let me tell you one more thing over here that all this which is happening over here is this all is happening at the level of neck of pancreas. So formation of portal vein is behind the neck of behind, posterior to the neck of pancreas. You'll see at the portal vein also. Okay. Okay. So superior mesenteric vein we have seen. Oh, now a couple of anastomotic veins. One is known as marginal artery of Drummond. Just look at the image, you will understand. It is actually the marginal artery because it runs on the margin of large intestine. The marginal artery of Drummond, also known as marginal artery, is an anatomical structure that connects the superior mesenteric with with the inferior mesenteric. It runs basically mesenteric close to the large intestine. That is point you should know. Forming basically vesicular arcade. So as we have seen that there are two arteries, superior and inferior mesenteric artery. So between them, to develop anastomosis, you have on the margins, you'll see in the diagram, you have a whole anastomotic vascular channels which are known as marginal artery of Drummond. Simple as that. Therefore, it is quite easy in gut. Suppose there is a perforation in the gut or there's any disease in the gut, you can easily cut that part of the gut. It could be even ranging from few centimeters to even half of the entire gut. You cut the part of the gut and you can then stitch them back again. That is known as resection and anastomosis. That is, you cut and you join them again. Cut and you remove the disease part. You take the two fresh ends and you join them. Why is it so easy? Because there is marginal artery like that. This artery serves as a anastomosis for the blood supply of large intestine. Clinically, as I told you, one R&A section anastomosis. But this is what we used to see a lot during our internship days in our medical college. Resection and anastomosis, a lot of gunshot or knife injuries used to come in the casualty. Clinically, it plays a significant role in the abdominal aortic aneurysm repair. That is one more use, as its presence along the branches of interiliac artery can provide sufficient blood supply. Basically, it's all about anastomosis. potentially eliminating the need of reimplantation of the IMR. Fair enough. So this over here, you can see, you can, I'm sure you can easily identify the colon, and this is your marginal artery of, okay, this is Menkovitz over, this is the marginal artery of Dumont over here. This all is a marginal artery of Dumont. Okay, and at the splenic flexure, there's one more anastomotic artery that is known as arc of Riemann. That is also, you should know, that is, there is one more extra anastomotic channel at the splenic flexure. That is known as arc of Riemann, apart from marginal artery of Dumont. Okay, now let us talk a bit of portal vein. Portal vein, till now we have seen, yesterday also we were discussing, that you have the superior mesenteric vein and you have bigger vein, the splenic vein. They both join to form the portal vein. First understand this part and then try to understand these, where are they actually lying. Let me write over here. The splenic vein is where it is behind pancreas. Where it is lying, it is behind pancreas. This I already showed supramesenteric vein. It is first lying in front of uncinate process. Then as it goes above, it also lies behind pancreas. So you can imagine that this whole area is actually, imagine it to be the pancreas over here. Okay, and this all is happening behind the pancreas. And portal vein formation is occurring where? At the neck of pancreas, behind the neck of pancreas. Other thing that you should know is that, imagine over here, this is the duodenum, right? This is a duodenum. There's your D1 part and you have D2 part like this. Okay, just keep on understanding. Be with me for some time. And then you'll see that the portal vein is going behind the duodenum. Then portal vein will go where? To which organ? Portal vein obviously will go to the liver. Okay, but the vein will not travel like this only, no? So what is actually present over here? What is actually present above the duodenum? What is this? This is the lesser omentum. So now this portal vein will run in the right margin of lesser omentum. So this area is what? This area is the, this area is what? This area is the right margin of lesser omentum. Let me just point it over here and write over here. This is the right margin of L dot O, because this whole is L dot O dot, lesser omentum. So portal vein is found behind pancreas. It will run behind pancreas, then it will run behind the first part of duodenum. Then it has to reach the liver. So it will be running on the right margin of lesser omentum. Or you can say then it forms the anterior margin of epiploic foramen. Because right behind this right margin, we have the epiploic foramen. Then obviously it will go and will divide into right and left branches supplying the liver. But on its way, the portal vein will gather some other tributaries as well that we'll see. So portal vein collects blood from all these areas, and transports it to the liver. Here you are seeing some important veins over here, but just to highlight so that you remember, focus on supramesenteric vein, focus on splenic vein. Okay, and see this also one more vein which is entering to splenic vein, that is the inferior mesenteric vein from the hind gut. Okay, all that will form what? Which vein? PORT, portal vein. And then you'll see that this going where? Into the liver. Okay, this what you should know. What is also being shown in this image, we'll see later on, that there are a lot of collaterals. And what will happen is, suppose tomorrow, that's also quite common worldwide, patient develops liver cirrhosis. Okay, that is, liver is not functioning. When liver will not function, this portal vein pressure will increase. Okay, organ is not functioning, so the venous pressure will obviously increase. When this pressure increases, then all the pressure in its tributary veins, they will also increase. So at its collaterals, that is where the portal vein is forming collaterals with the systemic vein. Systemic vein meaning by superior and inferior vena cava tributaries. So portal vein tributaries, wherever in the body, those tributaries are forming any sort of collaterals with superior inferior vena cava tributaries. At those areas, what will happen is that at the vena cava tributaries, you will say that, sir, here the pressure is okay. Okay, but here there's increased pressure. So what can happen is there can be episodes of bleeding over here. So we should know what? We should know the sites. Sites of what? Sites of bleeding. And what are sites of bleeding? The sites of bleeding are sites of portocaval anastomosis. You will see later on, this is so important. And the sites of portocaval anastomosis are, we will see later on. But try to understand this, I'm repeating again. In cases of liver failure, liver cirrhosis, there will be increase in portal vein pressure because portal vein is not draining the blood from liver, it is bringing the blood to liver. If the liver is not ready to accept the entire blood, obviously it will ask the portal vein to decrease the blood flow. It can't happen. Slowly, slowly, what will happen? Slowly, slowly, the pressure in the portal vein will increase. And at pressure, there will be retrograde increase in the pressure. Finally, that pressure has to open up somewhere. So at places where the portal vein tributaries are forming collaterals with the systemic vein tributaries, there, if one side this pressure is too less and one side pressure is too much, then there can be rupture at this part. Rupture of what? Rupture of these venous plexuses, and that will lead to bleeding, and that could be a serious bleeding. Therefore, you might have heard of that, or you might have seen in movies that people of alcoholic liver disease, alcoholic cirrhosis, they come with vomiting of blood. In movies also it is shown they're coming with vomiting of blood and things go really bad at that time. The doctors also say that okay, time is less and all those movie dialogues, but yeah, that is also not very wrong. So it is due to this gastroesophageal collaterals. You have vomiting of blood. Then blood coming out through the stools, hemorrhoid collaterals over here. Okay. Then different sort of appearance in the abdomen, you have umbilical vein collaterals and the region of umbilicus. Other regions as well. We'll see. So this was the portal vein, and now let us see some of its tributaries. Before let us finish this, portal vein is formed where behind the neck of pancreas. We have seen it ascends posterior to the D1 part and to enter the right edge of the lesser mentum. It's end in port hepatis. I have told you. Now, what are the branches? Actually, branches, or you can say what are the basically what are the tributaries? Which other veins enter the portal vein? Those are right branch will have cystic vein from the gallbladder, and left branch will also, this divided into ligamentum teres and ligamentum venosum. Parts and relations, they are showing over here the pancreas in this image, and this is the portal vein. Okay. In this format, I guess they are only telling the branches only. Mainly, it is a termination part, but we'll see. Yeah, over here, yeah, here are the tributaries. Tributaries are right over here. First, let me complete the tributaries. These are all the tributaries you must know. First, let me come to again that previous page. Don't worry about the previous page. The splenic vein is the largest tributary, and these both veins actually form the portal. Apart from these, you have the right and left gastric veins. I told you in case of when we are discussing the topic of stomach. Then you have superior pancreatic vein also. You can have cystic vein as well as paraumbilical veins also enter into the portal. Okay, so remember that. Now coming to this previous, what was this? See, if you know the course, you know that in the course of the portal vein, a part of the portal vein is below the duodenum, where behind the pancreas, that is known as infraduodenal part. Below the duodenum, behind the pancreas. So when it is behind the pancreas, anterelation is what? Pancreas. The other part of the portal vein is behind the first part of duodenum, that is known as retroduodenal part. Okay, therefore anterelation will be first part of duodenum. And third part of the portal vein we discuss is in the right margin of lesser omentum, where we had the whole portal triad. So here you are seeing even hepatic artery and bile duct related to the portal vein. This is known as supraduodenal part. So we have these three parts of the of the portal vein. This is very good in writing exams. The same thing, but you are describing it in a beautiful way. Infra, duodenal, retroduodenal, and supraduodenal part. Okay, it's a beautiful way you can write. Okay, now there's tributaries we also already discussed. What are the various tributaries over here? I want to discuss mainly about the anastomosis. Now come to the anastomosis. Anastomosis, these 4 or 5 anastomosis are a must know. We should know that around the umbilicus there's an anastomosis. So what you see if you remove the shirt and the t-shirt of the patient, around the umbilicus, if suppose this is the umbilicus, okay, then around the umbilicus you see the veins, the tortuous veins like these. What is this known as? This is known as caput medusae. Written over here, it is known as caput medusae. Have a just read about it. Left branch of portal vein communicates with superficial veins of empty abdominal wall. In portal obstruction, the veins of umbilicus become distended, resulting in caput medusae. We should know. Second point over here is lower end of esophagus. Remember, bleeding, Hematomesis, vomiting of blood. Now you should know which veins of portal on the portal side and which branches or which veins on the systemic side and anastomosis. At the lower end of esophagus, you have the left gastric vein. This is from the portal vein side. Anastomos with the esophageal tuberculosis zygosine, that is on the vena cava side. Okay, the hematomesis is vomiting of blood. Third region I told already, anal canal, again superior rectal vein from the portal vein side, and it anastomosis with the middle infrarectal vein. They are from the vena cava, mainly the IVC side. Okay, they might give rise to hemorrhoids, bleeding per annum. Then there's extraperitoneal surface or retro. See, behind the viscera, in the viscera we have the portal vein. Behind the viscera we have post-abdominal wall. What happens is, again, portal vein from here, and these veins which are of IVC, they are going to anastomosis. And finally, you have the bare area of liver also that can also give rise to collaterals. So bleeding can occur over here. Applied anatomy, all needless to say, we are discussing of the portal hypertension only. So just write about portal hypertension. Remember these sides. Don't forget to make diagrams like this. If not, then at least make diagrams like this. Show the collaterals, show the caput medusae, show the hemorrhoids. Okay, show the esophageal varices. You should make one or two diagrams. Then these parts of portal vein, again important. Tell the relations very easy. If you know the basic diagram, you will tell the relations. Okay, branches and all this. This was about the portal vein, right? So guys, this was about all the topics, and do revise them. Any queries, anything, let me know. We'll be more than happy to answer you guys. That's all. Again, before I finish off, have a look at this combo offer. Okay, this offer valid till July 15th. So have a look at it. And thanks for watching, guys. Thank you for your time. And any query, write in the comment box. More than happy to answer. Follow us on all these social media handles. That's all. Bye bye. Have a nice day.